Okay. If you look at the blood flow through the lung, very low. The actual resistance in the pulmonary circulation is very low due to large surface area and low resistance. Okay. Because of low resistance, you get low pressures inside the pulmonary circulation. So your normal pH pressure is around 20. Is acceptable systolic pressure of 25, and that's pretty good. There's not many smooth muscle in the arteries or veins of the lung. And actually, if you were to take the lung and flip it and hook up a vein and an artery separate, the resistive work is no difference. That's pretty impressive if you think about it. So pulmonary circulation in normal circumstances is irrelevant which way you're pushing flow through in the sense of resistance. There is no one-way valve to keep blood moving in the lung. Okay, these blood vessels are basically connected with low resistive elements, both of them. The other thing that's important about it is how blood flow travels through the capillaries inside the lung, inside the alveoli. You have two kinds. You have the capillary that's involved with transfer of oxygen and CO2. These are the ones that are the alveolar capillaries. And the other one is the interstitial, also known as the extra-alveolar blood vessel. Okay, there's two blood vessels that are going to alveoli. One is effectively going to allow gas to transfer, and the other one is going to cause shunt to take place. Under normal circumstances, if the area of the lung is actually adequately oxygenating, the sensor basically allows blood flow to go through the capillaries then. If you have an area where the oxygen levels are low in that alveoli, then the capillaries, pre-capillary-wise, they will be vasoconstricted and blood flow will travel instead through the extra-alveolar vessel, or will travel to other areas that are better oxygenated in the lung. That's really what it tries to do most of the time. Okay, but if you collapse too much of the lung, then more blood flow is going to go through the extraalveolar vessels, which is going to cause a huge shunt to take place. This person will not uptake oxygen because they have nothing to take on. Okay? So normally alveolar vessels are exposed to alveolar pressure and are compressed if this increases. So if you over-distend the lung, in other words, I inflate the lung too much, what will happen to my capillaries inside my alveoli? They will collapse. And when they collapse, then that will open up more of the extraalveolar vessel and as a consequence cause a temporary shunt. The extraalveolar pressures are exposed to a pressure less than alveolar and are pulled open by the radial traction of the surrounding parenchyma. Okay? So if you put a lot of traction, in other words, you hyperinflate the lung, not only do you compress the capillaries, but you also pull open the extraalveolar vessels so you get a greater degree of flow through there. Okay? Now, that being said, well, why is that really important? Okay? Because this will explain to you why you see desaturation when you inflate the lung properly in the operating room. Okay? Your biggest problem that you undergo when you put people under general anesthesia, it doesn't matter which one you use. It doesn't matter which induction method you use. It doesn't matter if you use muscle relaxant or no muscle relaxant. It doesn't matter which way you do it. You will cause a drop in FRC by 20%, period, across the board. That's a lot of volume drop. Okay? As a consequence, a greater proportion of your lung will develop atelectasis. In other words, it will start to collapse. And eventually, that person will become symptomatic enough that you start seeing drops in saturation. So what you're told to do is you need to re-inflate the lung. You need to re-expand the lung. And to do that properly, you need to generate what's called an inspiratory pressure hold maneuver. An inspiratory pressure hold maneuver requires that you close your pop-off and generate 40 centimeters of water pressure inside your circuit for 7 to 8 seconds. That's a long time, if you think about it. The old recommendation used to be 15 seconds. But really, the new recommendation is around 8 seconds. So you want 1 Mississippi, 2 Mississippi, 3 Mississippi, all the way to 8. Okay? When you're finished, then you release the pop-off. Now, what you will see initially, if you're observant, is that the saturation will immediately fall. That should freak you out. Okay? You should go to yourself, oh my God, the saturation is going down, not up. But actually, that's a good sign. Because if I over-distend the alveoli to get them to pop back open, what I've done is I've collapsed the capillaries and now have increased the amount of blood that goes through the extraalveolar vessels. So what happens to oxygen uptake for that brief period of time? It stops or goes down. So saturation falls precipitously. So you'll see the saturation go, let's say you're running at 94, and you do the inspiratory hold maneuver, you'll see it drop all of a sudden down to, let's say, 86 or 84. But in reality, that's actually a good sign. Because what will happen next is when you let go of the alveoli, again, after 8 seconds, now you have re-recruited the atelectatic areas. And as a consequence, the capillaries now reopen, and they're happy again because you're getting oxygen, so they uptake oxygen because there's greater surface area. So what happens with saturation? It goes zooming back up to 100%. Pretty cool. Okay? But it also tells you one thing. It tells you that I distended the alveoli like I was supposed to, so I recruited it. If I'm too much of a wimp, which I've seen people do this, they're too much wimp, they go, Dr. Nolan's like 40 centimeters of water, I can't do that, I can't do that, I can't do that. Okay? So they'll go 20. You see, and they think they're doing something. Okay? And I tell them, I'll say, okay, you go ahead. I'll be sitting here watching you. I'm going to laugh all the way to the bank. Okay? And I said, okay, let's watch what the saturation does. And what happens to saturation? Nothing. Doesn't go up, doesn't go down, does nothing. Because what you're doing is you're just moving a little bit extra volume in, but it's not going to the de-recruited lung. So it's only when you get that hyper-expansion back that you see your saturation fall. But let's say, this is kind of useful too, let's say I do re-expand the lung, right? And then I don't see a drop in saturation. And that should tell you something too, right? It should tell me that I really don't, the problem is not atelectasis. If I really generate 40 centimeters of water pressure and then the sats really don't drop, then that person does not have atelectatic portions of the lung. Or he may, but you're not really getting to it. What does that mean? Where do you think if I did a 40 centimeter water pressure change and I really don't see a drop in pressure and the CO2 is still staying marginally bad? Why would that happen? You're main stemmed. If you're main stem and you try to inflate, the other part of the lung is down already, right? It's not going to get any oxygen. So it's not going to extend that, so it's not going to desaturate. You might get a little bit of desaturation on this side, but it's not enough. Okay, the lung was already being over-distended already, so it's not going to see that much of a difference. Okay? So that's another way of tipping off your hat that maybe you have main stem intubation. Okay? I had that happen a few weeks ago. I had this lady who was 4'8". We intubated her at 20 centimeters. And during the case, she started desaturating. We pulled it back to 16 centimeters. And then the saturation came back up. It's pretty cool. That's how short her distance was between her airway and the actual. People get fixed into this concept, well, most women are 20. Yeah, most women are 20, but most women are not 4'4". Okay? So. Now, what happens when you alter the FRC? As lung volume increases above FRC, the pulmonary vessels outside the alveoli are distended and the resistance falls. Okay? On the other hand, the septal capillaries and the alveolar walls are stretched so that their eye diameters are reduced, and the net effect is an increase in overall pulmonary vascular resistance, since the narrowing of the septal capillaries is a dominant effect. So these individuals, the resistance goes up, okay, which is what's going up here. So you go up this way. So in other words, if you're over-distending a lung, what's happening to PA pressures? They're rising, and you're making the ventricle work harder against that, okay, which is a worrisome thing. Okay? Now that applies for normal lung. So if I put you on high levels of PEEP and you have normal lungs, then your pulmonary artery pressures are going to go up. Your resistive workload is going to go up for your right ventricle, and you may cause the right ventricle to fail. But let's say the lung is more collapsed, and I add PEEP to that individual, does that get transmitted into the pulmonary arteries? And the answer is no, not as much. Okay? So appropriate PEEP is the right thing to do, not It has to do with over-distension. It's how much radial traction you're putting up. Which one's worse to do? Atelectasis or increased radial tidal volume? And the answer is, if you increase the tidal volume too much, resistive work is going way up in comparison to collapsed lung. See the difference? Which one has a higher resistance? The one that's over-distended. Okay, so be very careful not over-distend your lungs. That's really not a good thing. Now, if you're below FRC, your pressure, in other words, this is FRC would be here. If your lung begins to fall, collapse, go towards atelectasis, then you will also increase resistance, but it's not as bad as the other one. So in other words, as lung volumes decrease below FRC, the pulmonary vessels outside the alveoli tend to collapse and their walls are no longer being stretched. Okay? The reduction in alveolar size leads to a reduction in stretch on their walls. And although resistance of the capillaries decreases, the overall effect is an increase in pulmonary vascular resistance, since the increase in the extra-alveolar vessel is a dominant effect. Okay? So that's what you end up seeing. So you still see an increase in resistance, but it's not as radical as over-distension. Okay? Now, how many people have taken care of people with ARDS? How many times did they put in Swan-Ganz catheters in those patients? Not many? All right, well, if you actually are studying hemodynamics on people that have ARDS, you will notice that they have a lot of high PA pressures. Okay? And if you look at it from a different perspective, most people say because it has to do with the resistance. Which is true. Part of it has to do with the disease process itself. But what is happening in essence is that somebody usually will try to ventilate these people with tidal volumes of 700. Okay, how many people had patients with ARDS were trying to ventilate the individual as they were normal lung? They would give tidal volumes of 700 to 600 or 800 tidal volumes. How many people did that? Nobody did. Not one of you that had efforts. You went to low tidal volumes. Who had their hand up before? You guys had low tidal volumes, what you used in your ICUs when you had ARDS? Or you gave normal volumes? What do you do? You gave normal tidal volumes? Okay. That's what normally people do. Most people don't understand that ARDS is basically disruption or basically collapse of a big portion of your lung. Okay, so what you end up doing is those areas are completely atelectatic. Okay, so instead of, let's say you're giving instead of using 5 lobes, you're maybe down to 1 lobe of effective tidal volume movement. Okay, so if you try to use high tidal volumes, what will happen is you'll get the following effect. You'll get this effect. On the one lung that's normal, you'll overstretch it and you'll get a greater shunt fraction. Okay? And what you end up doing over time is if you continue doing that is you'll shear this alveoli and tear it apart. And as a consequence, the left, what's remaining, will turn white and the person will die. Okay? And I've seen it done for years. And it's hard to get people to change. So what we try to do for many years, and first of all, we avoided getting into ARDS. That's number one. The second thing is when you do develop ARDS, volume is your enemy. You're not going to get volume into the patient. You're really down to, like I said, 1 lobe out of 5, maybe less than that. So what we used to do is we did what's called permissive hypercapnia. And we would float in a Swan-Ganz catheter, and then we would jump up on the tidal volume, believe it or not, until we saw the pressure inside the pulmonary artery rise. Why? Let's say we're giving a normal tidal volume here, okay, for this individual. This guy's got pretty sick lungs, okay, but we're giving him maybe a tidal volume of 400. Then we go up to 500 tidal volume, and all of a sudden the pressures rise very quickly in the pulmonary artery pressures. What did I just do? I overstretched the lung. So we would actually see it on our PA pressures. It was pretty cool. Then we'd reduce it, and that's how we knew how much tidal volume we could actually deliver to that individual. Sometimes we had to go to the tidal volumes as low as 250, which was pretty crazy. Okay, and we basically kept them alive by oxygenating them with higher PEEPs. and then we just looked for his tidal volumes of 250. So we allowed that person to develop what's called permissive hypercapnia. We let their CO2s get up in the 70s, 80s, and live there. And we waited it out for 4 days. If we reverse the ARDS disease process, which usually was an infection, then about 4 days later, all of a sudden the tidal volumes will start jumping up on us, which means that the lung is actually healing, and for the same pressure that we were giving, we were actually now generating more volume. That's when we were more careful in the sense of dropping our PEEP down, because that's when you get an pneumothorax, when the lung starts to heal. Okay, but it was another cool thing by understanding this, that your PA pressures would rise when you overdistend the lung. That's what it's trying to show you on the reverse side. So pulmonary vascular resistance is looking at input pressure minus output pressure over blood flow. The way I make you memorize it is put systolic minus diastolic pressure. So this is your pulse pressure in the lung over cardiac output. That can't be any easier. Think about it that way. Pulse pressure over cardiac output. So in other words, what would increase resistance? What would increase PVR? Greater pulse pressure. So if I have a greater pulse pressure, then PVR goes up. If my cardiac output goes up, then my PVR, if it's staying, it has to go down if it's going to stay, if the cardiac output is going up. Okay? So that's what you tend to see. If you see cardiac output rise, then the PVR, if it's not changing, will tend to go down. Okay? Tend to dilate more most of the time. So you do have different capacities in the lung to increase the cardiac output. Usually resistance doesn't dramatically change as you increase cardiac output. So very low resistance is due to vascular changes. As pressure rises, resistance tends to fall in the lung due to recruitment of more capillaries and distension of blood vessels due to increasing pressure. It's mostly seen in high pulmonary vascular pressures that you see this kind of effect of the distension. Most of the time it's recruitment. So you see this kind of thing. Okay, this is normal what we call recruitment. Recruitment is a predominating process. Okay, so in other words, it goes from, instead of having 5, it only operates only on 4. So when it goes to full recruitment, it operates on all 6 of them. So that's where you normally, sometimes you get into distension. That happens not very frequently. And the reason it's not very frequent is because this would not be giving you as good exchange as this. This gives you a more even distribution. This would be much more uneven. Okay, this would be called VQ inequalities. The very low resistance is due to lung volumes. As very large lung volumes increase PVR by increasing capillary resistance. That's if you get too much on the upper extension. So over distended the lung is not a good thing. And high resistance at low lung volumes as well due to critical opening pressures as well. So once you collapse the lung, also resistance goes up. Both of them will cause problems. This is what they were talking about in the last slides. So this is the big picture. Normally, the best place to be when you're looking at resistance is right at normal FRC. So you want to be here. So if you're a person that's normal, with a normal FRC, you're actually living here. Okay? If you go towards atelectasis, then resistance is going up. Okay? If you over-distend the lung, you're also going to increase resistance. What's worse? Over-distension of the lung is much worse. Okay? So if you're told, well, which one would be better? Would you rather have lower tidal volumes or high tidal volumes? I'd rather be at lower tidal volumes. Okay? Now, let me tell you how real this is. The number one cause of hypotension on induction is not medicines, even though some people will tell you that. The number one reason for hypotension on induction will be overventilation. People tend to overventilate. And that means that a very common error that people make when they're students is that once they intubate the patient, they close the pop-off and they squeeze a bag and they're not watching the manometer. And what will happen is, because their flow rate's at 10 liters per minute, which is what you're pre-oxygenating the individual and you're masking them with that, as soon as you close that pop-off completely, the pressure begins to climb radically on the centimeters of water pressure. What's the highest centimeters of water pressure usually that the bag will fill to? No, not 40. 40 would kill you. What do you think the number would be? You can actually see it. Next time we'll play with, when we take the sim lab, we'll hook up the ambu bag, the bag, onto the ventilator, and we'll close the pop-off and let it inflate. The pressure will go 10, 20, 30, and then it'll plateau. And then the bag will just get bigger. Okay? So the bag is designed when it hits 30 that it just continues to expand until it ruptures. But what's that mean to the person that's receiving this? That means they're receiving 30 centimeters of pressure inside their lungs, and their lungs are doing this. Okay, so their lungs are out here. And then you ask them, and the student says, I can't hear anything. And I said, yeah, you know why? Because gas is only going in and nothing's coming out. Okay, unless you're playing squeeze on the chest. Okay, so you need to release the pop-off. Now, also, the problem with doing that is what happens when you're generating 30 centimeters of water pressure inside the chest? What's happening to the heart? It's doing this, compressing. Okay, and every time it compresses down, eventually you have no volume, so no preload, and stroke volume drops off, and then your blood pressure goes to 0. And that's kind of a bad day. Okay? But that requires a long period of time. You're extending beyond the 7 to 8 seconds. 7 to 8 seconds is a long time in our job. Trust me, it appears to you as not being long, but in reality for us it's very long. Okay? So when you're squeezing the bag, you should look at your centimeters of water pressure and you want to hear breath sounds, and make sure that it goes back to 0. If you've seen the needle just move down to 20 and it comes right back to 30, hey, you need to open up the pop-off valve to get some of the gas out, and also to decompress the chest so you can get cardiac output out as well. Okay? Don't forget that. Students do that all the time. And, you know, it's one thing you learn really quickly. You don't need to do that. Measurement of pulmonary blood flow can be used in PICC method, and you can use the old equation here, which is carrying capacity minus your venous carrying capacity. The other way you can do it is cardiac output, which is oxygen consumption over your pulmonary venous content minus your pulmonary arterial content, which ends up giving you things called liters per minute. The way I want you to sort of remember for the test is you need to know what oxygen carrying capacity is. That's your hemoglobin times 1.34 times 10, okay? And we'll give you all those values here in a minute. The oxygen content of venous, I'm not going to worry about this equation right now. Just don't worry about the PICC equation. If you really are interested in this when we get to clinical, I'll be glad to sit down with you and play with this stuff. But it really, is it too much for you to know at this point? Yes. What I'm trying to get you to understand more so is that blood flow through the lung is more affected by changes in actual pulmonary vascular resistance and ultimately oxygen as well, which is HPV. Now the other thing I want you to understand is distribution of blood flow to the lung. That to me is critical. You have to understand that there's a difference in the way blood is perfusing through the lung. You have basically effectively 3, well there's actually 4, but we're going to keep it simpler. We're going to keep it down to 3, okay? Which is the 4th one would be including lymphatics, which are not included in this case. So we only have 3 zones, zone 1, 2, and 3. And each one of these zones has a different way that blood is traveling through them. If you look at zone 3, which is the most common area where ventilation is really taking place as well as perfusion, that is when you have arterial blood pressure, which is PA, is greater than your pulmonary venous pressure, which is then greater than your alveolar pressure. So in zone 3 of the lung, you get maximal perfusion. You get areas basically that get continuous blood flow throughout the whole cardiac cycle and through the whole respiratory cycle. So zone 3 is really where most perfusion is taking place. So when you put a PA catheter, where's it going to go? It's going to go to zone 3, period. Okay? If you're in zone 1, the alveolar pressure is actually greater than the arterial pressure, and which is greater than the venous pressure. So in zone 1, perfusion goes to 0. There is no perfusion. So where is this at? Where's zone 1? It's at the top of the lung. It's the apex of the lung. It's right up here. So the top of the lung has no perfusion going through it. Okay? This is the equation here. PA is greater than little a, PA, and little a, little b. Okay? And then you have zone 2, which is the hardest place to explain to students. Has anybody been to Germany? Have you ever seen a wind kessel? You ever seen a water wheel? Okay. A water wheel basically is a wheelhouse with buckets that have water pouring into them. Okay? As a bucket fills up with water, once the bucket fills up completely with water, it has enough weight that it then rotates the actual wheel. And that grinds stuff like mills and stuff like that. But it's intermittent, so it's not continuous. A normal water wheel that we think of is a paddle that continuously rotates with water running through it, which requires a high-speed energy stream to do that. Versus a wind castle just basically needs a little bit of water pouring in over time and eventually cranks over. So it's intermittent. So it's not continuous. And that's what happens with your lungs in zone 2. You get this intermittent flow where arterial pressure is greater than alveolar pressure, but alveolar pressure can exceed your venous pressure at certain times of breathing. So if I take in a big deep breath, okay, and my alveolar pressure is greater than my venous pressure, what happens to the blood flow to that portion of the lung? 0. So depending on which portion of the ventilation is taking place, I basically affect perfusion to that portion of the lung. Zone 2 is usually a minority of blood flow. I'd say about 70 to 80% of blood flow is going to zone 3. Zone 2 accounts for maybe about 15%, and then zone 1 accounts for less than 1% most of the time. Okay. Again, you see, zone 1, nothing. Zone 2, some degree of flow, and then zone 3 is where most of the blood flow is going through. Now again, why do you care, right? Why would you matter? Okay? Let me tell you why. Very soon you're going to be putting in PA catheters in people. Okay? So I'm going to give you an example. Okay? And what happens with different things in blood flow through the lung. If you're looking at, let's say, we're going to do a PA reading, which is a PA occlusion pressure. If you're in normal zones of the lung where you get continuous flow through it, your waveform that you would generate would be an A, C, and V. A, C, and V. Okay? That would be normal perfusion. So when you had your pulmonary occlusion pressure up, you would see an A, C, and V wave. It was continuous flow through it. Okay, does that make sense? Now let's put it in your situation that we're in zone 1 of the lung. And we put in a PA catheter and we get into zone 1. And then that individual, you put the balloon up. What will the waveform look like? If it's positive pressure ventilation, you'll see the following. It'll have no A or C or nothing. It'll just be going up and down. Because what you're really measuring is alveolar pressures. So the ventilator is telling you this fake number that you think that the person is adequate. What's the normal mean airway pressure for most people? 12. Okay? So what's your normal PA occlusion pressure? 12 to 15. So you're going to think right away, oh, this guy's fine. And in reality, this guy could be high or low because you're actually measuring not A, C, and V, where you're looking for C, but you're measuring just intra-alveolar pressures because you're actually measuring in zone 1. Now you ask yourself, well, how does that ever happen? How is it that I'm going to get a catheter into zone 1 of the lung? Because after all, Dr. Nolan says it's perfusion dependent, right? Here's how it happens. Okay? You're doing your clinical work. You're putting the patient to sleep. You got the patient intubated. And now you're working in hearts and you're getting all excited about your first PA catheter line in. So you're putting the guy in deep Trendelenburg. Here's your guy's head. Okay? Now, what happens to zones of the lung? This is now the lung looks like this. This is zone 1. This is zone 2. This is zone 3 now. Right? So you're supposed to take that patient and supposed to put him flat. But because you're so excited, you put the introducer in with deep Trendelenburg, which is what you're supposed to do. But then you're supposed to, the next step is to put the pipe flat before you put the swan in. But instead, you forget. Either you didn't remember that, you didn't think it mattered. So instead, you float the catheter in. Okay? And where is the catheter always going to go? The catheter always goes to perfusion areas. So the PA catheter ends up here. Okay? So now your PA catheter is in zone 3. That's perfect, right? Well, you take the patient to ICU, and the ICU nurse doesn't follow protocol like she's supposed to, okay, which sometimes doesn't happen, or because the doctor's there, the doctor says, ah, it's all right, just get a swan with the person sitting up. So now you take your patient, and now he is like this. Where is zone 1 of the lung now? And this PA catheter is still here. So now you're actually not measuring hemodynamics, you're measuring intra-alveolar pressures. And when you put the balloon up, it looks just like the ventilator waveform that's right beside you. If you were to look at it, it would mimic the same waveform. But it would be measurement of intra-alveolar pressure. Pretty cool, if you think about it. All right? Now, what would it look like? So that would be one thing, okay? And that's why it's clinically important to know that, okay? The other thing, too, is to think about it, is that in zone 1 of the lung, you're really not getting effective VQ match. So if zone 1 goes up in you, what happens to effective oxygenation and ventilation or CO2 removal? It goes down, okay? So let me give you a test question, okay? I'll give you an example. Let's say I take a patient and I begin to hemorrhage them. Okay, what happens to my zone 3 of the lung? Does it get greater, or does it become less? Less. Because as I bleed the person, there's less and less volume of blood going into the lung. So I begin to cause more of that. Okay, so there's less blood flow through it. So my overall area of dead space begins to dramatically increase. Does that make sense? So I've seen where individuals, you have a PA catheter in somebody, and you put it in a perfect place. The person was in a perfect situation, they were in zone 3. Okay? And then, during the case, all of a sudden, the waveform changes. It changes into this undulating pattern, and the person doesn't understand what they're looking at. But instead, they look at the number and say, well, the person's 12, I don't really need volume, they're okay. But in reality, what you're measuring is intra-alveolar pressures, and that person's really, their PaO2, their PaO2 is actually 0. You need volume desperately, but you're being fooled by the ventilator that you're okay. And usually the other kind of sign that something's wrong is blood pressure is usually like 80 or 90 or even less. And you're going like, what the hell's going on? Why is the PA pressures okay and my pressures are dropping like a stone? If you were to just take the swan and pull it out a little bit and let it refloat, you'd find out your actual PA occlusion pressure would be like 1 or 2 or 0. Does that make sense? Now, what happens if you get into zone 2? What happens if the catheter floats into zone 2? Okay? Because you get this intermittent flow in this situation, the PA catheter will give you a reading that looks like this, A, C, and V, A, C, and V. And then when the ventilator fires, you'll get this. And you get A and C and V. So intermittently, the PA pressures will exceed venous pressure, so blood flow will stop. So you get this undulating pattern in between. I'm sure all of you have seen this. Who has not seen that? I mean, all of you worked in the ICU. How many of you have seen that? I can tell you most of you did not recognize what it was. Okay? And unfortunately, what ends up happening is, clinically, people treat this as mean airway pressure. So instead, they measure it as here, and that's their true value. In reality, you can still use this value. That's still accurate down here. But the mean is usually what's used, and then people start thinking that, hey, this guy's okay, he's not dry like he appears to be. This is the person who's starting to bleed. This is the person that was in zone 3 possibly, starting to bleed, and now you see this undulating pattern show up. That means that you're converting into a zone 3 into a zone 2. Okay? And that individual, if you give them a little bit of blood, all of a sudden, now the waveform goes back to normal. Okay, because all you did was re-tank the tank, and now you're back into zone 3. Okay. I'm seeing glazed eyes a little bit. All right. Again, why is this also important? Let's look at it pulmonary besides vascular. Pulmonary-wise, you want to have the more zone 3 to ventilation equals, that gives you a better VQ match. If you have ventilation into zone 1, then you're going to dead space ventilation. Okay? If you're going to where you have perfusion, but you don't have ventilation, then that's considered shunt. Okay? So either one is bad. Okay? Shunt being worse, of course. Okay? But as you go into zone 2, what happens at VQ inequality? It goes up. This is why you have an R value of 0.8. When you do the math, thinking about math, 80% is what you have matching. The other 20% is basically areas where you're not getting good match to surface area. Okay. Zone 3, pulmonary artery pressure is greater than venous pressure and alveolar pressure. This is this one here. So you have continuous flow through here. And when you get your PA catheter reading, that gives you the most accurate reading. That's where you should float your swan in anyways. Okay, that's where it tends to go. It just depends on positioning the patient where it ends up being. Why care? As I said, affects PA catheter readings. Ventilatory management or ventilation can affect PVR, which can increase pulmonary vascular resistance. And alterations also in FRC may affect your PVR. Okay, now this is my examples that I was giving you with PA catheters. Most of you have seen PA catheters being inserted, so you put the pulmonary artery catheter in through the superior vena cava usually, and it enters into the right atrium, and then it gets floated into the pulmonary artery. And then when the occlusion takes place, it occludes the forward flow. So what you're really measuring is back pressure from the left atrium, which generates your A, C, and B wave. But that takes into consideration that the space that you're traveling, this pressure inside the alveoli can affect your readings. Okay? So anytime where you have the alveolar pressures exceed the arterial pressures, then you're really not seeing the left atrium anymore. So in zone 1, you're not going to see anything that's going on inside the alveoli. It's all taking place, a measurement of alveolar pressures. Now, we used to do this as part of an experiment because we wanted to see what zone 1, we wanted to see what alveolar pressures that were being transmitted in somebody's lung with ARDS. So what we would do is we would take this patient and put him into severe Trendelenburg, almost a head down, put the Swan-Ganz catheter in, and then flip them up. And then we would do an occlusion pressure, and we would measure their intra-alveolar transmitted pressure. Somebody who had more severe ARDS, what happened to transmitted pressure? It went down. So when you're worried about PEEP being more of a problem with people with ARDS, it's really less of one. But if you have somebody with bad COPD, with overextended alveoli, they tend to be very sensitive to changes in airway pressure or increases, because it makes the zone 1 distend much more so. Okay. If you're looking at dead space and shunt, dead space is an area where you're not getting any perfusion. Okay. This is the top of the lung, usually in zone 1. Way you look at it is, you can look at VQ. 1 is we still getting effective ventilation, and then Q goes to 0 on the bottom. I don't like this numbering because I don't really understand what that really means. I never multiplied 0 into 1 and made any sense of it. Instead, if I take this value of 0 and go 0.00001, well, I've done that kind of mathematics, and anytime you put a very low denominator underneath, then you get a much higher overall number. So that's why you're approaching infinity. That's what they're trying to tell you. You never get to 0 flow completely. It's always some degree of flow, but it's just very, very infinitesimally small. On the other hand, when you're looking at shunt, this is areas where you're not ventilating at all, and you're getting perfusion going through it. The example of that would be mainstem intubations, would be a situation where you're getting a AV malformation where you have blood going and bypassing the actual capillary network completely. Those are the degrees of shunt that takes place. Normal shunt to the lung is about 1% to 4%, depending on who you read. And those shunts are partly from bronchial circulation, and the other where the shunt fraction is taking place is through the basing veins in the heart. Now, what actually controls blood flow through the lung in a big majority is HPV, which is hypoxic pulmonary vasoconstriction. What the lung really wants to do is at the alveolar level, it's sensing oxygen that's getting there. So as soon as oxygen gets there in adequate amounts, it usually will want to increase blood flow to that area. So if an area becomes hypoxic, which means there's not enough oxygen getting to the alveoli, it makes absolutely no sense to keep perfusing it. So what the body does is it will increase pulmonary vascular constriction to that alveoli, and it will move blood to other areas that are getting adequately ventilated or oxygenating properly. Okay? Now, the book says that it's not dependent on central nervous system, but in essence, they're correct because it's a regional effect, but there's still an over control by the central nervous system. So when you have somebody with a severe head injury, what you see over time is that the VQ match gets worse with time. The only thing that can really explain that properly is that HPV starts going out of whack, which it does. Okay? Now, what we see under normal circumstances is that if the brain's still intact, it tends to be a regional issue. That's why they say that it's really controlled at the alveolar oxygen levels, which is a PaO2, and not the little AO2 concentration. So the sensor is inside the alveoli. If you increase the PaO2, which is the alveolar oxygen concentration, the greater the perfusion to that area. If you develop alveolar hypoxia, it constricts the small pulmonary arteries and basically restricts blood flow to that area. And this is again a more of a direct effect on the vascular smooth muscle that's around it. Where you see this as being really important is at birth. Your PA pressures are actually very high at birth because of HPV. As soon as you take your first breath and oxygen comes in, what happens to pulmonary vascular resistance? It dramatically falls. Okay? And with that, your right ventricle begins to remodel into its normal adult in about 3 years. Okay? But when you're born, your right ventricle is actually thicker than your left ventricle. Okay? Because of the pulmonary vascular resistance is actually higher than systemic vascular resistance because of HPV. Now, where does HPV really kick in inappropriately? It'll kick in ARDS like that. Okay? So areas that are really poorly ventilating will actually suffer from the hypoxia, and you get very high pulmonary vascular resistance pressures from that. As soon as you get oxygen to those alveoli, then everything gets better, and PVR actually falls. Now, unfortunately, when you put people under general anesthesia, what happens to HPV? Most general anesthetics, especially volatile anesthetics, inhibit HPV. And as a consequence, blood flow that normally would go to poorly ventilated lungs now begins to increase to those areas. Okay, so as a consequence, you get a greater VQ mismatch once you turn the volatile anesthetic on somebody. And there's really no way to get rid of that problem because you're basically inhibiting HPV. Now, of course, water balance in the lung is pretty critical. If you not careful, you can overdo water transfer, which is then you get into pulmonary edema. There's 2 stages to pulmonary edema, stage 1, stage 2. In stage 1, you're just moving volume into interstitium. That increases the actual lung weight, which decreases the pulmonary compliance. Okay? It makes the lung stiffer. And if you wait too long and the pulmonary edema continues, it can then get fluid into the interstitium and into the alveoli space itself, and then you get what we call frothy pulmonary edema, or you get really bad stage 2 pulmonary edema. We get fluid in the alveoli itself. The other functions of the lung is it acts as a reservoir for blood. Okay? When you suddenly lie down after standing, quite a bit of venous blood returns in the legs back to the right atrium, which then goes back to the pulmonary circulation. It's able to distend and accept that extra volume without too much of an effect, unless you're in failure. Okay? The right ventricle pumps the extra blood into the lung, but not all of it immediately moves to the left ventricle. So some of it's just stored in the lung until it has time to remove it out. Not a big deal for most people, but patients that are already in congestive heart failure from left ventricular volume overload, when you lie down, they become even more symptomatic and actually will not like it. They will actually try to sit up immediately and say, I can't get any air in. That's because your lung is getting overweight and you just can't take in any more volume in that situation. This prevents cardiac output from increasing excessively when it goes from upright to lying down position. This is a reservoir effect. On the other hand, when one goes from a lying down to an upright position, that blood pool now is holding their extra volume for your left ventricle to work off of, so it doesn't cause a rapid drop in blood pressure as well. It also, the other thing that functions in the lung is it acts as a filter. It's very important as a filter in the sense that it's able to knock out little blood clots. It's able to do that. Small air emboli, it also can knock out very easily. If you get an air embolus and you see it transferring to the left side, that's pretty obvious that it's not because of the lung. At that point, you usually have a PFO, which is a patent foramen valve, or an ASD or a VSD. Something's going on that's allowing air bubbles to transfer from the right side of the heart to the left side. Okay? The other thing that it's also able to do is actually able to remove bacteria. But usually when you see that happen is a person will develop pneumonia following it very quickly. Okay? If you didn't have the lung acting as a filter, any small clot would immediately transfer over to the left side and you would embolize to the brain, which would not be a good thing, and you would also have increased incidence of having heart attacks. There's also metabolic functions to the lung. There's many conversion reactions that are taking place. You have things like arachidonic acid metabolites that convert prostaglandins E2 and F2. And you also have leukotriene productions that's also produced in the lung itself. You have an increased production of prostaglandins and thromboxane that are responsible by the lung itself. The type 2 alveolar cells make also pulmonary surfactant. This is essential for normal compliance of the lung. You also have converting enzyme, which remember if we talk about that's about ACE all the time, angiotensin converting enzyme, which converts angiotensin 1 into angiotensin 2. The other thing that it does is it converts active bradykinin into an inactive metabolite, which is also important for blood pressure control as well as coagulation. If you look at the metabolic functions, it also makes immunoglobulin A, which is a component of the mucus, which helps in keeping the person's bronchioles from getting infected. So people that don't have adequate production of immunoglobulin A have an increased incidence of developing bronchitis and chronic lung infections. The upper airway secretions secrete mucus, which is essential for removal of inhaled particles, the mucociliary mechanism. And the lung also removes serotonin from the blood, which is things that are transferred from platelets. The lungs can also partially remove and inactivate things like norepinephrine and epinephrine, which is pretty important if you think about it. I've seen epinephrine given intracardiac, especially if you get really lucky and get it into the left ventricle. The effect is dramatic. The first time I ever seen this back, I thought I pretty much brought somebody back from the dead. This guy had been no blood pressure for 15 minutes, no pulse. They already given him 3 milligrams of epi, no effect at all. They were desperate because the IV line was pretty poor, so I put a central line in. Okay, we put it in pretty quickly. I thought it was amazingly quick how quick I got it. I'm going, man, really good. You know, it was really impressive. I gave a milligram of epi through that new central line, and I tell you, within 15 seconds, the blood pressure went up, heart rate turned over, and it was like magical. I'm going like, man, am I good? Okay, and then I look at my IV bag, and I'm starting to see bright red blood coming back through the IV bag. What did I put it in? I put it in the subclavian artery. Nice. But I brought the guy back from the dead, you know? So we actually had to go to the operating room and open up the guy's chest and got the subclavian artery exposed, and then put a suture on it, pull the central line out. But the guy did fine. He actually survived the event and got to go home. So, you know, why not go right to it? Why not just pull it? Don't do that, please. Okay? One of my friends did that one time, and it happened to me about 3 years ago. We had a patient that we were putting a central line in, and something didn't quite seem right, and the CRNA that I was working with got a little bit too aggressive. And then after we put the cordis in, he saw bright red blood coming back through the cordis. And I looked at him and said, that's not good. And he said, well, you're going to pull it out. I said, no, you're not. You're going to call the vascular surgeon. This is an open heart surgery patient. And I said, no, we're canceling the case and we're going to have to repair this. So the patient, of course, the open heart surgeon was not happy. He had a few four-letter words to give me, which is fine. You know, I take my hits when I need to, because we all make mistakes. And what ended up happening was he went in there and he said, oh, I just quit compression, pull it. I said, absolutely not. He said, if you're not willing to go in there and repair it for me, I'm going to get a vascular surgeon. I'm not having it pulled. So he looked at me, kind of really got more angry. He's like, you know, it's my decision. I said, no, it's not. It's my decision. I put the catheter in. I'm not letting you do it. So I said, okay, fine, all right, I'll go in and fix it. So he opens up the neck and starts flowing down there. And he said, well, it's carotid injury. And I said, I don't think so. So he goes down further, and guess what? Carotid artery is perfect. Didn't get into the carotid artery at all. Okay? It actually was through the through the superior vena cava. The wire had gone through and hit the innominate artery. So now the cordis was in the innominate artery, which was down here. If we had pulled it, we would have hemorrhaged 2 liters or 3 liters of blood into the mediastinum, and the guy would have died. And that's what's reported in the literature. Instead, what we ended up doing was just put a small little stitch in the innominate artery, pulled the cordis out, sutured it, and we were done. Woohoo! Small incision. Patient was not happy. We had to delay his surgery for 24 hours. Then we did this open heart the next day, and he did fine. Okay? So that's what I learned that day. Don't do stupid stuff. I saw my friend do stupid stuff like that. I saw one of my friends pull a cordis out of it, but supposedly the carotid artery ended up being also an innominate artery. I also saw a surgeon put a subclavian catheter in and hit subclavian catheter with a dilator, and it was actually not subclavian vein, but it's a subclavian artery. And at that point, I already learned that it's not a good idea to pull it, and he still pulled it. And it was a disaster. Hemoglobin went down to 3 and kept her alive by pure luck. So that's what you learn. If you put in a catheter, it's not good. It's okay. Just tell somebody and then have them fix it for you. If it's something that you can get to an artery that's further out, maybe you can stop the pressure and it'll be okay. But I would really recommend that you really put a suture in it. Usually that's all it takes. The other metabolic factors that the lung is able to do is it's prostaglandin E2 is produced by the lung of the fetus. It serves as a smooth muscle relaxant, keeps the ductus arteriosus open during fetal life. And elevations in pulmonary and systemic PO2, which occurs with newborn and causes this production to slow down. Okay? If the ductus fails to close, inhibitors of prostaglandin synthesis, indomethacin, can basically be administered to facilitate closure of the ductus arteriosus, which is what a treatment of this is. Okay? If you keep the PGE2 levels too high, then the ductus will stay open.